Chapter 19, Disorders of Cardiac Function. This is a high-level overview of some of the disorders of cardiac function that we may see in our patients. When we're talking about cardiac function, we're talking about disorders that may take place in the pericardium as a result of cardiac coronary heart disease or as a result of myocardial disease. All three of these disorders can cause symptoms of both right and left heart failure. Pericarditis is an inflammation of the pericardium that creates a restricted movement of the heart, either due to the serous fluid filling the pericardial cavity as a result of the inflammatory process, and we call that a pericardial effusion, or it can be a constrictive pericarditis related to fibrous scar tissue that makes the pericardium stick to the heart, and this would be, for example, related to someone who has a complication as a result of having radiation for chemotherapy. The main sign and symptom that we see in patients that bring them in is a chest pain, and we may see some EKG changes related to the restriction of the pericardium or the movement of the heart beating. And last but not least, we may, upon auscultation, hear a friction rub within the heart chambers as we're listening to heart sounds. The bottom line is, if we don't take care of a pericarditis and this effusion continues to build up around the heart, it creates a situation called cardiac tamponade, where the heart becomes so compressed that it can't breathe and it becomes an emergency. So pericarditis, usually caused by some sort of a viral infection, can be treated with antibiotics, but if not treated, can result in a serious situation called cardiac tamponade. This is just a high-level concept map showing the consequences of pericardial effusion. Here on the right-hand side, these are the ones that you'll see in terms of signs and symptoms sooner versus later. You'll see increased venous pressure, jugular neck vein distension because of that increased pressure. The later signs and symptoms that you'll see are signs and symptoms of a decreased cardiac output where the blood pressure is significantly hypotensive, and you'll see signs and symptoms of shock. Those will be late. Our goal in nursing is always to find the signs and symptoms sooner versus later. In coronary heart disease, we've talked about this a little bit in the last chapter. Atherosclerosis is the number one cause of blocking the coronary arteries. This ischemia may cause chest pain or angina. It may create a situation where they're having an acute myocardial infarction or a heart attack. It may just cause cardiac arrhythmias. Just to know that it can cause heart failure and sudden death also. So atherosclerosis in the coronary arteries is a serious disease. High-level overview of coronary heart disease as it relates to either chronic ischemic heart disease, where you're having ischemia to the heart, or acute coronary syndromes, where you're having acute changes in the conduction of the heart that create a situation for acute MI. In talking about chronic ischemic heart disease, the underlying pathophysiology is that there's an imbalance in the blood supply and heart's demands for oxygen. So there's less blood, either because of the atherosclerosis, because of some sort of a clot, a thrombosis, or because of a vasospasm, generally occurring during a higher oxygen demand situation, such as stress, exercise, or cold. This is a nice picture of how chest pain radiates, and these are all the areas where a patient may complain of chest pain or angina. The kinds of angina you can have would be stable, and this usually occurs when the heart's oxygen demand increases. So any of those situations that we talked about before, stress, cold, or usually it happens during peak exercise activity or stressors. You can have variant angina, and this is where the pain occurs because the coronary arteries are spasming, not because of any cause of exercise externally. And then there's silent myocardial ischemia, where there is no pain at all, but there is a decreased blood flow to the actual heart via the coronary arteries. That's a silent killer. In acute coronary syndromes, here's where people come into the hospital and you see us mounting a rapid response to treat them, because what we've found out over the years of treating coronary syndromes is if we treat this quickly and fast and get them down to the cath lab, we can save heart muscle and decrease the incidence of long-term heart failure for the rest of their life. So essentially these patients come in, we hook them up to the EKG, and we see significant changes in their EKG. We see T-wave inversion that we didn't see before if we have an old one to match up to. We see ST segment depression or elevation. That's a key sign in acute coronary syndromes, and we may see an abnormal Q wave. We also take blood and look for serum cardiac markers because when the heart cells become necrotic, they release certain proteins. We look at the myoglobin, we look at the creatinine kinase or CKMB, and we look at troponin levels. All three of these lab tests will show an increase. Troponin is particularly sensitive to cardiac markers, where myoglobin could be elevated because of other muscle breakdown. In an acute myocardial infarction, the patient presents with severe crushing or constrictive chest pain in any of those areas that we showed on the picture. What we know is women's chest pain is much different than men's, and they may complain of a heartburn type situation, and we're doing a big push to make sure that women recognize that this heartburn could be the result of chest pain from an acute myocardial infarction. You may also see a sympathetic nervous system response, so a lot of nausea, vomiting, and GI distress, a sense of impending doom and anxiety and restlessness, tachycardia and vasoconstriction, diaphoresis, very shocky. The blood is being shunted back to the heart, so you'll see weakness in the arms and legs, a coolness in the arms and legs, and a decreased blood pressure. We know that if we don't treat an acute MI quickly enough, we can have multiple complications due to the death of the cardiac tissue. We can have irreparable heart failure. Cardiogenic shock is a huge side effect of big acute AMIs. Pericarditis can take place. Thromboemboli because of the rhythm disturbances, and rupture of the heart and ventricle aneurysms is something that can happen but doesn't happen often. When the heart muscle malfunctions because of heart failure, it can be due to three separate reasons. You can have ventricles that are hypertrophied because they have to work so hard to get blood inside of them and out to the body, so they become all built up, kind of like when you weight lift, your muscles get built up. That's a good thing for your abs and your thighs and your biceps, but not such a good thing for your heart. Ventricles can become too stiff to stretch, and we call that a restrictive cardiomyopathy. So the heart muscle can't expand to receive the amount of blood that the body needs, and they don't contract enough to get the blood out. So you have an inability to alter your blood flow because the heart can't pump the way that it's supposed to. And then sometimes we have ventricles that are too weak to pump out the blood when we have acute MI or dilated cardiomyopathy. The bottom line here is that the heart muscle needs more oxygen and performs less efficiently, so the person has significant negative impact to their daily activities of daily living. Last but not least, not that you have to understand all the valvular disorders and heart defects that occur in the body. I'm not even going to talk about any of the heart defects, but I want you to understand that what happens in valvular disorders is that there is an interference with the normal blood flow, causing either signs and symptoms of either left or right-sided heart failure. The mechanics of these valves can decrease cardiac output and are usually identified by heart sounds. Depending on which valve they're near, the sound happens either in the systolic or the diastolic segments of the pumping cycle. So I won't go into all the different kinds of heart sounds. You just need to know that they are abnormal and there are extra sounds